So right heart failure syndrome is characterized by inability of right heart ventricle to generate enough stroke volume. That results into the systemic venous congestion, underfilling of the left ventricle, and in the most advanced cases, cardiogenic shock. Because right is not pumping enough blood to left, so left output also goes down. It can cause cardiogenic shock. Right heart failure portends a poor prognosis in almost every clinical scenario. So this is the anatomy of the right heart. As you can see, right heart is the most superficial structure if we go from the chest side, and it's a crescentic shape, and there is an intraventricular septum between right ventricle and the left ventricle. Anatomically, ventricle is a thin-walled, low-pressure structure in comparison to the left system. It's a complex crescentic shape in the contrast to the left ventricle, which has simple ellipsoidal structure. So as you can see here, this is the left ventricle and this is the right ventricle. This is the pulmonary valve. This is the tricuspid valve. So you can see this is the left ventricle, and left ventricle is almost engulfed by the right ventricle. Owing to the curvature of the interventricular septum in the normal heart, the RV is described as a wrapping around the LV. This is why RV is a crescent shape. And this particular shape, as well as the connection of the two ventricle through the interventricular septum, constitute the interventricular dependence. These are the different parameters of the right heart. The shape is crescent shape. Structures is a two layers of the fiber. Free wall thickness is 1 to 5 mm. Circulation is a low pressure, low resistance type of system. Stroke volume 70 to 90 ml. Ejection fraction 65. Ventricular pressure from 0 to 8. Ventricular pressure systolic is 15 to 30. Afterload in DIANS is a pulmonary vascular resistance less than 250. Afterload for right ventricle is obviously the pulmonary vascular resistance. Adaptation to disease tolerant to preload, but hardly poorly tolerant to afterload. This is the comparison between RV and LV. We need to discuss this comparison because we have to understand the pure physiology of pathophysiology of the RV problem. So if you can see, it's a low resistance, high capacitance, whereas the left ventricle is a high resistance system. Myocardium in the right ventricle is thin and compliant, whereas in the left ventricle it is a thick and non-compliant, or maybe less compliant than the right ventricle. It adapts very well to the preload, whereas the left ventricle adapts very well to afterload. Blood supply is with the right coronary artery, free wall, and the posterior two-thirds of the septum, and left anterior descending with the apex and anterior one-third of the septum. Left ventricle has got left anterior descending and left circumflex. Perfusion both during the distole and systole, whereas in LV it is perfused only in the diastole. A typical filling volume, the normal RV is highly compliant chamber. It is relatively insensitive to the changes in the preload. What I mean by the relatively insensitive, if I increase the preload, majority of the time the output of right ventricle increases at the minimum pressure changes. At high inflow volume, pericardial constraint interferes with the ventricular filling and compliance falls that we will discuss in the future slides. Right ventricle is extremely sensitive to the changes in the afterload. So if the PVR goes high, right ventricle faces the brunt. RV is thin walled. Any increase in the afterload can lead to pronounced increase in the wall tension and therefore oxygen utilization. So this is the two graphs of the right ventricle and the left ventricle. As you all know, the cardiac output is equivalent. So this is the reference point where both the cardiac output are equivalent. This is the cardiac output. If you see the graph, the curvature of this graph of right ventricle, if we increase the pressure little bit, the right atrial pressure, cardiac output is increasing in a great amount. Whereas in the left ventricle, the atrial pressure goes very high to get the desired cardiac output. That's why we say that it is very sensitive for preload and it tolerates very well the preload. What happens with the afterload? As you can see here, the normal left ventricle tolerates afterload very well, whereas in the right ventricle, if you see, the movement means the vascular pressure is going up, the stroke volume is going down. Coming to ventricular interdependence, or what we can say the ventricular coupling, it's a phenomena whereby the function of one ventricle is altered by the changes in the filling of the other ventricle, because it's a concentric shape and they are interconnected with the interventricular septum, not by way of the flow, but they are interconnected by a single wall. Size, shape and compliance of one ventricle affects the other. It is the result of direct mechanical interaction of sharing of the common interventricular septum and the pericardial sac. So as you can see here, systolic ventricular interdependence, it contributes the contribution of left ventricular septal contraction on RV up to 40% of the right ventricular systolic function is attributable to this mechanism. So what is happening? When the LV septum is having contraction, this is the septum, interventricular septum, when it is contracting, it also pushes the RV, this RV systolic function is 40%. So this also pushes the blood flow from RV. Diastolic ventricular interdependence, this happens in a diseased heart, as you can see here, seen in the acute right ventricular pressure or volume overload states, where the right ventricle is highly dilated in comparison to the left ventricle. Normally, left ventricle is more in the oval shape. Here it is a D-shaped left ventricle. So this extra fluid or dilated RV pushes the intraventricular septum towards the left ventricle, and this causes the decrease in the filling of the left ventricle and cardiac output goes down. So this is the decoupling of the ventricular interdependence, when the RV pressures are too high or volume is overload. And here you can see the outside is the pericardium. So up to a certain extent it can dilate, the pericardium can accommodate. If it further dilates, it cannot dilate further, because the pericardium will obstruct the dilatation of the right ventricle, acute dilatation of the right ventricle. So RV filling is extremely sensitive to changes in intrathoracic pressure. Right ventricle afterload, that is the pulmonary vascular resistance, varies with the lung volume. As we all know, if we change the lung volume, if the lung volume is very high, overdistended, again the pulmonary vascular resistance goes high. If the lung volume is very low, atelectasis takes place, again the pulmonary vascular resistance goes high. So RV afterload changes in both the condition. Atelectasis area increase, hypoxic pulmonary vasoconstriction. Overinflated area, compression of the pulmonary capillaries takes place. PEEP can decrease pulmonary vascular resistance by opening the closed unit. So where the atelectasis is causing the increase in the pulmonary vascular resistance, PEEP can be beneficial in such area, but it can increase the pulmonary vascular resistance where the overinflated areas are there. So it again can cause both the things, increase in the pulmonary vascular resistance and decrease in the pulmonary vascular resistance. Pulmonary vascular resistance increases with the acidosis and hypoxia, because both can cause pulmonary vasoconstriction. Dramatic decrease in the pulmonary vascular resistance is by the nitric oxide, inhaled nitric oxide. Pulmonary embolism dramatically increases the pulmonary vascular resistance. As we all know, it is causing a obstructive type of shock, so pulmonary vascular resistance goes high. The pathophysiological mechanism of right ventricular failure can be conceptualized as acute or chronic abnormalities of right ventricular load. It could be preload or afterload, and myocardial function. It could be contractility, as we say inotropy, and active relaxation, lusitropy. So here the active relaxation takes place, that is very important in the filling of the right ventricle. This is a little overburdened slide, overcrowded slide. As you can see, these are the four causes of the right ventricle failure: the excessive preload, excessive afterload, reduced inotropy, and reduced lusitropy. This is the molecular mechanism of the right ventricular failure. Could be because of the hypertrophy, could be because of the ischemia, could be because of the metabolic dysfunctions, and could be because of the fibrosis. So let's come back to our basic pathophysiology again. The RV pressure causes, these are the causes of right heart failure which we face in the clinical practice. The right ventricular pressure overload, it could be because of the endothelial dysfunction of myocardium, vasoconstriction, and mechanical obstruction, as we see in the pulmonary vascular resistance, increase in the pulmonary vascular resistance. RV volume overload, pulmonary or tricuspid valve regurgitation, left to right shunt due to interatrial defect. Then anomalous pulmonary venous return could be causing this volume overload. RV contractile dysfunction, as we see in the right ventricular myocardial infarction, intrinsic myocardial disease such as cardiomyopathy, such as septic cardiomyopathy, left ventricular assist devices in the presence where acute unloading of LV is being done, and LV dysfunction. So these are the causes of decreased contractility. There could be acute reversible causes like ischemia, hypoxia, metabolic acidosis, hypocalcemia, hypophosphatemia, exogenous substances like certain poisons, endogenous substances like cytokine release, hypo and hypothermia. And chronic causes could be coronary artery disease, idiopathic, inflammatory, alcoholic, postpartum, uremic, nutritional, metabolic and toxic. Why the RV load after load is elevated? It could be in the acute condition in pulmonary embolism, hypoxia, acidosis, ARDS, sepsis, acute elevation of left atrial pressure and positive pressure ventilation. In chronic cases, it could be chronic hypoventilation, recurrent pulmonary emboli, primary pulmonary hypertension, chronically elevated left atrial pressure and connective tissue diseases. So they can cause RV afterload elevation. Right ventricular failure in cardiac conditions, this is a pure clinical setting. Again, it's a little repetition, but just to simplify it, cardiac condition could be coronary artery disease where RV infarction is there, valvular heart diseases, cardiomyopathy like ischemic or dilatative, a heart surgery, post CABG, ABR, MVR, heart transplantation, and post LAVD. So left ventricular assist device because they over empty the left ventricle. Extracardiac conditions could be pulmonary embolism, lung diseases may be COPD, ARDS, primary pulmonary hypertension, sepsis, lung transplantation and post-thrombectomy patients. So as we can see here, these are three the most commonest thing which we deal in the ICUs, mainly the coronary artery disease, pulmonary embolism and lung disease, which are the most commonest we see in the ICU day to day. Right ventricular failure rarely occurs in the setting of normal pulmonary vascular resistance. What happens in the acute pulmonary embolism? It causes acute right ventricular or dysfunction or right ventricular failure due to an excessive acute increase in the afterload, which is secondary to the obstruction by the clots of the obstruction of the pulmonary vasculature, constriction of the non-obstructed area, and intracardiac hemolysis resulting from the turbulent flow across the pulmonary valve. So these three phenomena are happening here. At least 40% of the cross-sectional area must be obstructed to significantly increase the pulmonary arterial pressure. Echo is the good modality. It can find around right ventricular dysfunction in 30 to 56% of the normotensive patients with PE. All-cause 30-day mortality rate is around 5.4 to 10%, and in hospital mortality rate directly attributed to pulmonary embolism was 1.1 to 3.3%. Cardiogenic shock occurs in around 5% of the acute pulmonary embolism cases with 90-day mortality is more than 50%. Right ventricular cannot acutely overcome a systolic pulmonary artery pressure more than 50 millimeter of mercury. Conversely, acute and chronic right ventricular failure can tolerate significantly higher pulmonary arterial pressure. What happens in the ARDS? How this right ventricular dysfunction happens in the ARDS? Incidence of acute right ventricular dysfunction in ARDS is around 30% to 56%, depending on the definition of criteria of right ventricular dysfunction, severity of lung disease injury, and ventilatory strategy. Associated with increase in the 28-day mortality, even in the lung protecting mechanical ventilation era and Berlin definition of ARDS. Both pulmonary hypertension and right ventricular contractile impairment are the main factors involved in the right ventricular dysfunction. Mechanism of ARDS induced acute right ventricular dysfunction includes hypoxic hypercarbic vasoconstriction and increased alveolar dead space, pulmonary microthrombi, pro-inflammatory cytokine activation are the most common. So, four predictors of the acute right ventricular dysfunction in ARDS: pneumonia-induced ARDS, where PaO2 FiO2 ratio is less than 150 millimeter of mercury; PaCO2 is more than 48 millimeter of mercury and driving pressure is more than 18 centimeter of the water. So routine echocardiography is recommended in all ARDS patients with a score of equal and more than 2, allowing an early implementation of right ventricular protective strategy that might prevent right ventricular dysfunction. Acute cor pulmonale is extensive, can be happen in the presence of extensive alveolar collapse, severe hypoxia, which can cause the vasoconstriction. Mechanical ventilation may increase both pulmonary artery pressure and pulmonary vascular resistance because of the hyperinflation of the healthy lung units and the high PEEP. High PEEP, high tidal volume can cause acute cor pulmonale. So incidence of RV dysfunction increases with the severity of ARDS in the presence of high tidal volume, high plateau pressure, and acute cor pulmonale is 10% for the plateau pressure between 18 to 26%. More than incidence is more than 30% for a plateau pressure between 27 and 35 centimeter of the water, and incidence is more than 60% for a plateau pressure more than 35 centimeter of water. So just imagine how much our patients are prone to develop acute cor pulmonale. What happens in the right ventricular myocardial infarction? RV myocardial infarction can be complicated by acute right ventricular dysfunction in 30 to 50% of the patient with inferior wall ST elevation MI. Severe hypotension and low cardiac output are present in 10% on the admission. Right ventricle tolerates ischemic injury better than the left ventricular because it has a lower oxygen demand, greater coronary flow reserve, dual and right and left coronary artery supply, and homogeneous transmural perfusion across all the cardiac cycle, both as we saw systolic diastolic. The right coronary artery usually is the culprit vessel in right ventricular myocardial infarction, and more extensive RV myocardial necrosis is associated with proximal RCA occlusions. Acute outcome of the patients with right ventricular MI is primarily determined by the amount of accompanying LV necrosis. How we diagnose the right ventricular failure? Can have ECG with the like right atrial right axis deviation, right bundle branch block, RV strain pattern, S1Q3T3 pattern as we see in the pulmonary embolism. Some laboratory investigation like NT-proBNP, echocardiographically, we'll discuss a little bit later. CT pulmonary angio or CT dilated pulmonary arteries, dilated RA-RV, retrograde flow of contrast into IVC or hepatic vein can be seen. Cardiac MRI, right heart catheterization, pulmonary artery catheter is a gold standard still. So this is the summary of all the investigations: elevated BNP, right atrial in echocardiography, the dilatation, ventricular hypertrophy. I don't want to go into much detail of all this. Coming to the echocardiography, so just remember these 6 images in your mind. They are very important in diagnosis of the right ventricular failure. Tricuspid regurgitation, peak systolic velocity of TR, tricuspid, this TR jet is more than 2.8 milli per second, meter per second, that is the peak velocity. Tricuspid annular plane systolic expression, what we call as a TAPSE, more than 17 mm, as you can see here. RV dilatation, RV end diastolic diameter and LV end diastolic diameter, the ratio is more than 1. RV basal diameter is more than 41, as you can see here. Then we call it as a right ventricular dysfunction. RV fractional area changes less than 35 in distal systole. Ventricular interdependence, septal shift and D-shaped LV, as you can see here in the systole and in the diastole, both it's moving here. This is the pressure overload because of the pressure. When the systole, LV is in systole, and in the diastole it is because of the volume. Systolic S-wave velocity of the tricuspid annular is less than 9.5 centimeter by this Doppler tissue imaging. So principles of managing the right heart failure: preload optimization, RV afterload optimization, treating the cause of RV failure, mechanical circulatory support and RV contractile support, that is there. Prevention of acute right ventricular failure in ICU begins with the identification of high risk patient, for example patients with severe ARDS or inferior wall MI. Avoiding increasing RV afterload and decreasing RV contractility. Then optimization of RV preload, applying the RV protective ventilation strategies, maintaining the sinus rhythm and atrioventricular synchrony by using either pacing or cardioversion. So, how to resuscitate a failing right ventricle, treat the cause, improve preload, improve contractile, same principles. The maintain aortic pressure, how to maintain critical to continued adequate right coronary artery perfusion and avoidance of RV ischemia. So, if your systemic pressure, systolic pressure is going down, we have to bring it up by using the vasopressors. Levosimendan may improve contractility and decrease pulmonary artery pressure. Reduce RV afterload by correct hypoxemia, correcting acidosis using the vasodilators. Pulmonary vasodilators could be inhaled nitric oxide, levosimendan could be sildenafil in a chronic patients. Fluid therapy in RV dysfunction, proper management of volume status is essential for the failing right ventricle. Both hypovolemia or hypervolemia can cause decrease in cardiac output as we have earlier seen. RV preload requirement differs substantially based on the whether afterload is normal or increased. Acute right ventricular dysfunction in the setting of increased right ventricular afterload like PARDS, where we have to restrict the fluids. Acute right ventricular dysfunction in the setting of normal pulmonary vasculature resistance, where the MI is there, right ventricular myocardial infarction is there, more liberal fluid reposition to maintain cardiac output. Mini fluid challenge can be done to assess the clinical scenario like ARDS. Limitation of the dynamic fluid responsiveness predictors in the fluid management wherever right ventricular failure is there. So it is a limitation. Sign of the venous and systemic congestion are present. Intravenous diuretic should be first option followed by the renal replacement therapy in the patients with diuretic resistance where we feel that fluid overload is there. Mechanical ventilation in RV dysfunction. The main principles of mechanical ventilation for patients in acute RV dysfunction is limiting the tidal volume and the peak. Therefore, limiting the plateau pressure less than 7 centimeter of the water and driving pressure less than 18. Avoiding hypercapnia, preventing and or reversing the hypoxic pulmonary vasoconstriction. The presence of right ventricular dysfunction and not the PaO2 FiO2 ratio could be an indication for proning. So majority of the time in the ARDS patient we take PF ratio as an indicator for proning, but in patients where we are suspecting the right ventricular failure, the right ventricular dysfunction is more important for proning the patient. It can unload the right ventricle by recruiting collapsed alveoli without causing over distension and reducing airway pressure and hypercapnia. That is what we call RV protective ventilation strategy. Pharmacological treatment, the aim is to have a predominant ionotropic property, avoid pulmonary vasoconstriction, maintaining systemic perfusion pressure. Norepinephrine and low dose of vasopressin can be used where the systemic pressure are low. Both dopamine and epinephrine are not recommended because of the arrhythmogenic properties and increased myocardial oxygen demand. Ionodilators, milrinone, levosimendan has been recommended for acute right ventricular dysfunction treatment. Pulmonary vasodilator like inhaled nitric oxide can be used and it is having very short half-life and making it as an ideal agent for management of pulmonary hypertension or hypoxic pulmonary vasoconstriction in critically ill patient. Oral pulmonary vasodilator like sildenafil can be used in a chronic patients. These are the mechanism and targeted management of the different things: right heart infarct, pulmonary embolism, decompensated PH, ARDS, non-cardiac. We have covered almost everything of this. Mechanical support: when medical therapy for acute right ventricular failure in the intensive care unit is ineffective, then one can think of mechanical support in the form of ECMO or right ventricular or biventricular assist devices. RV function may be acutely diminished by increase in the PVR due to obstruction of the pulmonary artery, right ventricular contractile dysfunction, effect of the intermittent positive pressure ventilation and the PEEP. Right ventricular resuscitation must include maintenance of the preload but preventing septal shift, maintaining RV perfusion pressure, reducing elevated pulmonary vascular resistance and optimizing ventilatory strategies. So we have already covered almost of this. This is a little busy chart where they have defined how to manage acute right heart failure, lung protective ventilation, then treat pulmonary hypertension, treat pulmonary embolism, and so on. Volume overload is there, then CRRT, renal replacement therapy can be used. Hypovolemia, one can give little bit of the fluid. RV infarct, acute P and hypotensive shock, volume challenge can be given, and rescue therapy as atrial septostomy, right, RVED, ECMO, and transplantation can be done. So to conclude, acute right ventricular dysfunction or right ventricular failure is seen with increasing frequency in the intensive care unit and causes or aggravates many common critical illness diseases. Bedside echocardiography assessment and invasive hemodynamic monitoring remain the most valuable methods to diagnose and to guide a rational therapy of acute right ventricular dysfunction or right ventricular failure in critically ill patients. General precautionary measures, early diagnosis of right ventricular dysfunction and etiology specific therapy may reduce appearance of right ventricular failure. Supportive therapies focused on the improving RV function via optimization of preload, enhancing contractility, and reducing afterload are the key principles in the management of acute right ventricular failure. Thank you.